handle the data easier. And so that's why Dr. Cheryl Sherpical modified it down from the original RAPS down to RAPS 4 because it was easier to, on the data.
Yeah. It's your turn, Lexi. Oh.
Did make a significant difference. All right. So we're looking at I also took a look at the beliefs of blacks with regards to hypertension. Blacks were more fatalistic than whites. Like, oh well, I have it. But that's part of it is because it's a norm for them. They know someone who has it, their mom has it, their brother has it, their sister has it. It's kind of a norm. Only 20% of Caribbeans were unable to identify the causes of hypertension, which means they knew what caused it, okay? And they had more knowledge than their white counterparts. 80% felt that they could tell whether or not their blood pressure was elevated. And they say things, oh, look, my head's hurting me, or, you know, I've got a serious headache. That was something that more blacks had that phenomenon than whites. 93% of blacks knew that high blood pressure could kill them, but only 37% of them worried about their blood pressure, whereas 57% of the whites worried. Now, it wasn't like they weren't worried, it was like, oh, my doctor will take care of it. So it was not like I don't care, it's just my doctor's going to take care of it.
Well, that goes along with number one, they're more fatalistic.
Right. But then, this is quite a mixed bag. These things don't all sort of land on the same side of the line here, because now they're more concerned about taking drugs for a long time. So they're more inclined to stop taking their medication when they feel good. Like, my head isn't hurting me today, I'm not going to take my medication. And then they're more inclined to try and use herbal remedies. And all of this variation down here happens without them telling their doctor. They'll stop and they'll start and they'll try different things without their doctor knowing. So it's very hard for the doctor to have any good outcomes on their medication. I should also point out that between blacks and whites, it takes more medications to control. A white person might be on 2 meds, but a person of color, they might be on 4 or 5 meds to try and control their blood pressure. Okay, so I did my study in London to evaluate the beliefs, attitudes about hypertension amongst Seventh-day Adventists living in London, and to examine the relationship between risk factors that predispose them to hypertension. Okay, here are my research questions. Now, I have all these questions, and I don't know if I have all the answers for you today in terms of the information I was able to fish out for this presentation. So, the first question is, what are the knowledge levels and common lay beliefs concerning hypertension? Question 2, what are the levels of the health belief model, and we'll talk about that a little later, of perceived susceptibility, severity, benefits, and barriers related to controlling hypertension? Is there a relationship between the levels of the health belief model variables related to presenting hypertension and the behavior of hypertension risk factors? And number 4, what is the relationship between the behavioral variables and blood pressure levels controlling for demographic variables? All right, so my theoretical framework was the health belief model, and the core constructs of that model are these ideas of perceived susceptibility. Do I think I'm going to get it? And is my risk higher? Perceived severity. So if I get it, how bad is it? Perceived benefits. It's like, if I do something to prevent getting it, is it going to be worth it? And barriers is like, oh, this is just too much effort. I'm not even going to bother to do it. Too much effort for me to try and make a change here. And perceived self-efficacy, which says, I know what I need to do, and I believe I can do it, or I believe I can't. This is the whole description of self-efficacy. And this is the model that I trying to develop for the study. So here we have the health belief model variables, and these are the controllable variables. Now, because I was looking at, and I developed a questionnaire to look at all of these variables here, but because I was working with an Adventist population, a conservative Adventist population in the UK, I didn't ask about smoking and alcohol because I would cause them to tell lies. They wouldn't confess if they weren't using it. So the question that I did ask was, in the past, before you became an Adventist, were you? But any current usage of alcohol or tobacco would not be admitted to. So we didn't include that variable in our study. So.
More, similar to working with Muslims.
All right, you know all this stuff, the IRB, cross-sectionals. It was convenient sampling. I actually ended up going to 17 of the churches in London and collecting. My sister's a nurse, so she helped me to collect the data. And there were 18 locations that I went to, and a couple of people took them to their homes. We measured blood pressure, and the anthropometric measurements were waist circumference and BMI. All right, inclusion criteria: members of the church living in London between 25 and 79 years of age, self-described as black. And exclusion was reported use of alcohol, tobacco, didn't have any of those, and diagnosed with hypertension. I had a few people who filled out who were actually diagnosed, so we lost some of the surveys because of that. And we lost a couple of surveys because of age, people were too old. So we had 352 people volunteered, and ultimately I had 312 surveys included in the study. So here's the breakdown. 68.9% of the people who took part were female, 31.1 male, oh boy. 55% were Caribbean, 10% African, and 35% UK born. So African was quite a small percentage, actually. So the questionnaire that we developed looked at their diet: vegan versus vegetarian versus meat-eating, BMI, those are the risk factors, physical activity. We'll rush through this because we don't have much time. Okay. All right. SCSS 14. See how long ago that was? That's a dinosaur. Okay. All right. So we did descriptive stats for the demographics, knowledge, behavioral variables, and age variables. We did linear regressions for the HBM variables and the risk factor, and the relationship between behavioral variables and levels of blood pressure. All right, so results. I don't have my data on knowledge, so we just got a summary statement here. On average, the respondents scored 73% on the knowledge scale. They knew the right answers to what causes blood pressure, can I change blood pressure, and so the knowledge wasn't an issue. But most health educators will tell you that knowledge really impacts behavior.
That's true.
Right?
That's
So,
so true.
so they have the knowledge. All right. There was a negative association, this was interesting, a negative association between education and systolic blood pressure. And diastolic blood pressure. And these were both significant. And the literature said that that wasn't quite consistent in the UK, but I had that, we did have the SES, that inverse relationship there. So that was the results on knowledge. Okay, so the relationship, the health belief model of constructs, it was a 5-point Likert scale, with strongly agreeing down to strongly disagreeing. They were kind of in the middle for susceptibility to the disease, perceived barriers, and for perceived severity, this was the only variable that had a significant association with either systolic blood pressure or diastolic blood pressure. So as their perceptions of the severity of hypertension increased, their blood pressure levels decreased. And this is from my regression. Okay, being significant and family history being significant for diastolic blood pressure. I mean systolic blood pressure, sorry. And then for the diastolic blood pressure, the relative risk score. Oh, I developed a relative risk score. I should have told you that. Okay, there's a relative risk score that they developed out of Harvard for heart attacks and for cancer. And I kind of pulled them together and developed a 10-year relative risk estimate for strokes. And using those scores, I ran the regression. So that was significant in terms of for diastolic blood pressure. This was close significant for all right. All right, so compared to the national data, there are only 3 behavioral variables where this sample was better, because I compared to the health survey, the UK health survey. We were better in salt use, and that was one of the largest things. Blacks knew that if you put salt in while you're cooking, it's better than adding salt at the table. So they didn't add salt at the table, okay, as compared to the national data. Their BMI was actually better, and the waist circumference was better. And you know the risk factors for stroke, 102 centimeters for men, women, I don't remember. There's risk factors for the waist circumference, I apologize. But again here, knowledge did not translate into behavior. And like I said, there's self-efficacy associated with behavioral variables. The strength of this study is that as Seventh-day Adventists, we have a broad range of dietary habits. We have those who are vegan, and we have those who eat